Before I begin, I would like to acknowledge the traditional owners of the land on which we meet today, the Kakadu people, and pay my respects to elders past, present, and emerging. So I'm Nausheem. I'm a fourth year dentistry student in Cairns, and today I'll be presenting our research project where my team and I are looking at evaluating the perceived preparedness of recent BDS graduates with recognizing, responding, and referring patients who have experienced domestic violence. Our research team consists of my co-investigators, who are Averil, Gerlin, John, and Manisha, and our supervisors are Dr. Felicity Croker and Dr. Anne Carrington from JCU Social Work. So why dentists? Why should dentists and dental students work in this space? For a number of reasons, actually. So in a submission to the Royal Commission of Family Violence, the Royal Australian and New Zealand College of Psychiatrists cited research which claims that 76% of women who have experienced domestic violence present with head, neck, and facial injuries, and that they would cancel their medical appointments, but they would tend to attend their dentist ones. And further research published by Australian Institute of Health and Welfare, which released a media report, says that DV is the leading cause of hospitalization for young women and girls, with most common injuries that they present with being strangulation marks, bruises, scratches, fractured bones, and teeth. Coulthard and Warburton, who looked at the role of a dentist in domestic violence, state that missed appointments, multiple recurring injuries that the patients try and hide, and partners unnecessarily accompanying patients being potential indicators to domestic violence. And the Royal Commission also received submissions which stated that dentists are willing to help in this space, but they lack the specialized training that would be required. So there is a need for specialized training in this space. A bit of background. So we define domestic violence as being physically, sexually, emotionally, and economically abusive, threatening, or coercive, or in any other way controlling or dominating, which makes a person fear for their own safety or that of others in their care. And we wanted to make sure that our research project did not have a gendered agenda. Rather, we're looking at an issue of violence and dominance that affects both male and female. So NROSE, which is the Australian National Research Organisation for Women's Safety, published data based on the publications of ABS in 2016. They produced infographics such as this. And these statistics show that women and men are victims of domestic violence. And I'd like to point you towards the statistics that highlight the male perspective of DV, because this is equally important in a debate, because they are often marginalized in this debate. And combined with the marginalization in an already stigmatized issue, men who have experienced domestic violence can often have added stigma, which prevents them from disclosing that they have experienced it, due to perhaps perceived ideals of masculinity. Fortunately, they do have resources available, such as the Men's Line hotline and websites, which point them to further support services. And NROSE also states that 61% of females had children under their care during the violence, when the violence took place. 73% had experience with more than one incident. 58% did not contact the police at all, and 24% did not seek any advice or support whatsoever. And a report published by the Australian Institute of Health and Welfare, which is titled Family, Domestic and Sexual Violence in 2018, states that women who present with domestic violence these days suffer, 35% of them suffer from anxiety and 32% with depression as a result of DV. Let's look at rural and remote Australia. What does this mean for rural and remote Australia in the modern times? Well, in a submission to the Australian Parliament, Phillips and Vandenberg claim that rural and remote Australians are less likely to report domestic violence, so the statistics in this space aren't very clear. So comprehensive data for at-risk groups such as rural and remote Australians aren't prevalent because of that. And there is also evidence to show that in rural and remote Australia, people have a stronger adherence to traditional gender roles, and there's a perceived lack of confidentiality. You know, small town, everyone knows everyone, so people find that their privacy may not be respected as much, which is another barrier for people who want to report and disclose domestic violence. And in terms of structural and cultural barriers, there are structural barriers being limited access or lack of services due to remoteness, and cultural barriers being social stigma. And the Royal Commission into Family Violence also looked at a few submissions where they claimed that access to Medicare-funded counselling services were difficult through specialist services in rural and remote Australia. So the role of a dentist is the care for a whole patient and not just their teeth. And as part of our undergraduate studies here at JCU, we get taught a plethora of skills that make us competent in rural clinical practice. And one such program is the DVRRR program, which I will be talking to you about. And this program teaches us skills and sets us up to continue to learn, because each place, wherever we are placed or where we intend to practice, will have different legislation and services. So it shapes the way we practice to continue to learn and grow. So the grey area, so this is where we don't have any clear course of action or answer to a particular case. So a patient comes in and we suspect that they may have experienced domestic violence. Our job is to recognise, respond and refer with the informed consent of the patient. However, because DV is a result of a dominance dynamic, an imbalance of power in an intimate relationship, it's important to understand the patient's circumstance and their willingness to seek help. It's important to not coerce the patient or put them in a vulnerable position when you have this conversation. For example, in Northern Territory, mandatory reporting is legalized. So you are legally obliged to refer that patient in that scenario. But otherwise, what do you do? It's a hard call to make. And a few things can help you make the ethical decision, chief among which are consent, record keeping, professional judgment, and legislation in the area of where you practice. So the DVRRR program is the first of its kind in undergraduate dental education here in Australia. This program was designed based on the feedback that our faculty received from Year 5 students who had the clinical competence to treat the dental implications of DV, but they lacked the skills necessary to respond and refer. And this program is what we are doing our participatory action research on, which allows us to evaluate and co-design the program based on our research findings. This program is a result of collaboration between JCU Dentistry, Social Work and Cairns Domestic Violence Service. It's a scaffolded approach, so in JCU Dental we start treating patients from Year 3, so this program follows us from Year 3 to Year 5. And there's been a lot of media coverage nationally and internationally about our program, which we are really grateful for, and we also think it adds to the social and professional responsibility of DV. And it's important that solutions such as this is highlighted in the media so that we can have a productive debate about DV in the public discourse. So we are building on the previous project, which looked at recognizing and responding to domestic violence, exploring the role of a student dentist. So this study was conducted in 2016. Their mixed method study was a two-stage study that looked at a pre and post intervention survey that looked at Year 3 students and Year 4 students, and a focus group with the 5th year students. So they've had recommendations which say that ongoing evaluations of program should be done and further consolidation as well. So this is a summary of their results. So as you can see, with pre and post intervention, both Year 3 and Year 4 students perceive the importance and relevance of the program and the value of the workshop. They do recognize that it's important. So coming to our project, what are we going to add to this? We think that by evaluating the perceived preparedness of JCU alumni from 2016 and 2017 in recognizing, responding and referring to domestic violence based on their undergraduate degree will help us add information about the long-term impact of our educational initiative. So why did we choose graduates? We think that looking at graduates in this program will offer us a fresh new perspective, since the past study looked at undergraduates. And we also think that in looking at whether they apply the skills or not, we can feed that back into the undergrad program in terms of effectiveness and impact and see where we can work on. And the findings, as I said, will also inform the DVRRR program for JCU undergrad students. So we have 3 key objectives of our research. The first one is to investigate whether the alumni feel more prepared following the program. Second one is to assess their knowledge after they've had the program, since it's been a few years after graduation, and to investigate their perception and to see if they perceive any gaps and recommendations to fix that. So our research project will will take in the form of a single stage survey, and we intend to recruit graduates from 2016 and 2017 through the alumni Facebook group. We have representatives from both of the cohorts who have agreed to help us get the word out and hopefully get as many people as possible recruited. And we hope to email a survey link to our SurveyMonkey survey to their most recent active email address of choice. And currently our survey is going through the ethics approval process at JCU. So once we get that and once we get the data collection going, we hope to use SPSS and thematic analysis for that. So in terms of limitations, the main one that I'd like to highlight is the inability to reach both of the cohorts. And this is more so because we are doing an online survey. Online surveys usually tend to have a lower response rate compared to paper-based surveys. So we aim to mitigate that by using our representatives to let them all know that we're doing this. And since they've done a research project back in their undergrad years, we hope that they will empathize with us and join and help us get as much data as possible. And self-selection is where we think that people who are interested and invested in the study will be more likely to participate. So we hope that in letting everyone know that we get a variety of data and we can have the diversity of responses that we need to enrich our study. So where to now? What's our plan? After we collect the data, interpret it, and the dissemination of our findings, we hope that it will help inform future DVRRR programs for undergrads as well as for professionals in the field. Currently, our faculty is working closely with the ADAQ, which is the Australian Dental Association Queensland branch, in formulating these programs for professionals in the field. And we had a program which was run in Cairns in June, which was well received by the local dentists. And we have another program currently, which is a work in progress, set to be held in Brisbane. And we also received a lot of interest from other undergraduate dental universities because they see the relevance of this program in their own course, and we hope to expand this one-of-a-kind program and work with other universities as well. In terms of our own research project, we hope to get published in peer-reviewed rural health journals, as well as present at further collaborative conferences such as these. I'd like to thank Are You Remotely Interested in the team that work here for the opportunity to present our work. My team and I are really grateful for this opportunity. Thank you.